Medicine as a public resource. I didn't always think of medicine as a public resource. It doesn't really come naturally. As a doctor, I think, well, I paid for my medical education. It's natural to think that I don't really owe some debt to society beyond what I've already paid. But the reality is that a lot of taxpayer dollars go towards medical education and retaining people who practice medicine into certain areas or the country as a whole. So the taxpayer spending on just healthcare in general in the nation is about $1.6 trillion. It's a huge amount of money. I can't even fathom that amount of money. And then locally here in Washington State, according to an article by the Seattle Times, we're spending about $125,000 per year per medical student to fund their education. That's, of course, apart from what they're actually paying for their medical school education. So why do we do this as a society? The reason is that we're expecting some kind of payoff, a payoff in the form of available medical care, which just makes sense. That's something we all need. You know, it is the function of government to try to facilitate these basic needs for the community. And so this interface is a very real thing that's happening and affects how we get our care, how expensive it is, and the quality of it. So it only makes sense that the more work that we can get out of these highly trained professionals, and I'm not just referring to doctors, I'm referring to nurse practitioners and physician assistants and even nurses and medical assistants and everybody on down the line. So the more work that we can get out of all of our professionals, the more value we get as taxpayers in terms of benefit. So it's really important that we incentivize people to work for long careers, and there are ways that we can set up to facilitate that. And there are also things that happen that make it less likely that they're going to work for long periods of time or that they're going to continue to do the same work that we've helped support as taxpayers. When I think about the healthcare system, I think of where the bottlenecks are at. Where are the processes or people that are slowing the process down and making it harder, painful, and just generally a real drag? And oftentimes those things are the things that involve the provider, the doctor, the nurse practitioner, the physician's assistant. What I mean by that is if you have your most highly trained member of the team and their signature is required for something that you're trying to accomplish, then it can't move forward until you get their signature. So it becomes a choke point. You can do all the preparation in the world, but if it requires a signature, you can't move forward until you have that signature. And these are complicated things. So, I mean, the signature is probably the most simple example, but it's also training and experience. So, for example, I'm board certified in family medicine, and in order to work in certain jobs, I have to be board certified in family medicine. I also have to maintain my emergency response credentials. And if those things that are required by either my employer or by law aren't met, then I can't work. Also, there are things in laws that affect the way that I'm practicing. So for example, in Washington State, we have laws concerning controlled substances and how often we see people who regularly take controlled substances. And that is an issue of how we distribute our time. If we are required under the law to have so many visits for that reason, for evaluation and management of controlled substance, by necessity, that means that you don't have space for other things on your schedule. And this is a decision that we've made as a society that that's an important topic, and those people need to have those regular visits. There's also cultural things. So there are certain things where a person will make an appointment because maybe they've received some advice from a provider who's not their regular provider, but they're not sure if they trust it. So they want to have another appointment with their PCP to run it past them. So in that scenario, something has required 2 appointments instead of 1, whereas if they could just get to what they wanted the most, which was an appointment with their PCP, then maybe they would have avoided the first visit. So there are a lot of things like that that have to do with how often someone needs to be seen, with how urgently they need to be seen, that affects the quality of care that you receive and the quality that the healthcare team feels that they're providing and their satisfaction with their work. And if you don't have satisfaction with your work, then sometimes you stop practicing, sometimes you retire, sometimes you find something else to do that you find more fulfilling than the practice of medicine. And that's a sad reality that we're dealing with, is that people are leaving medicine because they are dissatisfied with some aspect of the work. So what can we do to try to limit the amount of dissatisfaction and keep people working longer and seeing as many patients as is reasonable, and just giving good value to the public? I think there are 2 things that come to mind. One is team-based care. So having a whole team that is involved with the care of patients is super valuable in terms of, say, freeing up certain members of the team to do what they can only do. So if it's the doctor needing to sign something, then it frees them up to sign something. Although I don't like that example, I'll get to that in a minute. But certainly the evaluation, the medical decision-making is super important and is a bottleneck that occurs naturally in medicine. But even, say, there are certain things that we have nurses on the team do, like wound care, where that's a fairly time-intensive intervention for patients, and it's often best done by our nurses, and they're really good at it. So having them do that instead of the provider do that is often the best solution, or the best use of time, the most efficient use of the team's time. There are a lot of moving parts in medicine, so having a team member that's involved with billing, involved with answering the phones, those are often all different roles among the medical team, but if they're all working together from the consumer's point of view, from the patient's point of view, that gives a sense of high quality, especially when it's, sort of in the same office where they go, that's so-and-so at the front desk, I recognize them, or somebody that they've talked to about their bill possibly. Again, that's that high quality, high efficiency care that we're all striving to provide. So in medicine, our teams are pretty expansive. They not only include the clinic where you might be seen for your wellness visits and kind of day-to-day routine things, but it also can include specialists that are hard to get into, specialists that might not even be in your own hometown. And I may need to refer someone out for cancer care, or they may just have something that's quite unusual or hard to diagnose that it can't be handled in the town that we're in. When we refer to people that are specialists, often the medical record plays a huge role, because if we're all on the same medical record and I can see results from their visits immediately as soon as they sign their note, that's a huge degree of efficiency. Also, if the medical record has a way of just sending a little short message to a provider, that can be very efficient also. When I think about people on the healthcare team, that also includes who would take care of you in the hospital. And sometimes people don't realize that every service is not available at every hospital. And when a service is not available at a particular hospital, they have to transfer you to a facility where it is available. So knowing ahead of time what service might affect your care would be the ideal situation. Like, let's say you had someone who was bleeding from their intestines and you needed to do a scope from above and a scope from below. And if that wasn't available at a particular hospital, then you would probably want to go to a hospital where it was available to begin with, because they're going to have to transfer you anyway. And in a perfect world, hospitals would coordinate that kind of situation, whether they were competitors or not. And the reality is that it's not always coordinated well. You don't have to look very far and know very many people that have been admitted to the hospital to see that those things aren't coordinated well. And that directly relates back to medicine being a limited resource, and that the public needs to get their value out of their tax dollars. And so that coordination, which is very complicated, is something that should be addressed. And I am interested in patient advocacy, especially with regard to efficiency and things like this. I know that there have been some laws passed about, say, access to your own medical records and the way that you're billed for the services that you receive at the hospital in terms of transparency. And I think those things are great, but we still have a long ways to go. If you can think of something that you think is related to the limited nature of the medical resource and how we might improve it, put that in the comments. I'm interested to know. I may add it to a future video. So the last thing that I wanted to talk about was, how do we get rid of the things that are making our job less fun, making it seem much more attractive to be sitting on a beach and drinking something cold, which would always be attractive, I guess. But we also have a strong desire to want to do what we do. We've spent our whole lives training for it. And so there are definitely some things that affect how our day-to-day work is that make it more or less fun. So laws are really important. Sometimes laws have unintended consequences. Like I was mentioning earlier, if there's a requirement for so many visits to be scheduled for particular types of patients under the law, then that by necessity means that those spots can't be filled with other patients. And ultimately, I think that this should rest on the shoulders of the provider, because they're ultimately on the ground doing the work. Also, laws affect training. So if it's difficult to get certain types of training that are required, that may slow the process of hiring or changing jobs. In terms of hiring and changing jobs, one of the worst aspect of it is getting credentials all set up. We have to have credentials for individual insurance companies. Even if I am in the same state, I might be in the same town. When I change jobs, my tax ID number has changed at that point, and now I have to get all new credentials for the very same insurance companies that I just had them. And that can take anywhere from 3 to 6 months pretty often. So those are often requirements of the insurance companies. If it's, say a national program like Medicaid, it's requirements of Medicaid. Sometimes when I think about how work flows to me, I just am flabbergasted. So, for example, because of our culture, we'll get assigned work from, it's unpaid work. It will get assigned unpaid work from all kinds of people in the community. It may be a lawyer's office in terms of signing paperwork about somebody's ability to make decisions. It may be your local public schools who are insisting that a patient have a note for excused absences. It may be people's work is requiring a note about an excused absence. It may be a state program where you have like family medical leave, where it's required that certain paperwork be filled out. And even though sometimes there really is a benefit to the patient and that's something that we would be on board with, there are lots of times where it's not. And I think we have to ask ourselves, are some of these things really a good use of a provider's time? I can think of a few that I don't think is a good use of provider's time. Certainly, sick notes for mundane things seems to me a poor use of a doctor's time. It also seems to be a poor use of doctor's time to fill out paperwork related to prior authorization. So prior authorization is when an insurance company doesn't cover a certain medicine and I prescribe that medicine not knowing whether they cover it or not. And when it goes to the pharmacy, then the insurance company says, no, you can't have that medicine. And then a whole process is started where we try to figure out what is a covered medicine. And then when we do, if we find something that is an equivalent that will work and we prescribe that medicine, then sometimes that works, sometimes it doesn't. And sometimes literally they don't cover anything for that particular category, let's say weight loss. But that's not what they tell the patient often. What they tell the patient is, well, if your doctor just fills out this paperwork, then it's covered. But what they don't tell the patient is that the only way that will work is that they cover it, say they cover a weight loss medication for a patient if they have diabetes. Well, if the patient doesn't have diabetes, there's nothing I can do. You know, and yet going through that process, you don't always have the you usually don't have the information up front. And so it requires a lot of time and effort to and money and resource to get to the end result, which oftentimes is, no, you can't have this medicine, which was the same thing that we found out before we went through the process. So making that much more straightforward, making it so that a prior authorization process cannot be used as a hurdle that at some point we'll say, well, we're not going to do that hurdle. And then it makes it seem like it's the doctor's office's fault or the doctor's fault that a patient isn't able to get any particular medicine, when in reality, this was a decision made by the insurance company to have only these certain drugs on their formulary, and it has nothing to do with us, and we really shouldn't be involved in that. The only time it really makes sense for me to be doing prior authorizations is when there's new drugs that are just coming out and maybe they haven't had time to be included on the formulary, and so we have to sort of make the case that this is a special circumstance that someone needs a medication. There are also other things that affect whether that's a good use of time, say the cost of the medicine. There are many medications that in the United States are quite inexpensive, say $8 a month, something like that. Well, if the medicine is only $8 a month, or if the medicine is over the counter, then why would we pay a medical office, why would we expend the amount of time and resources that would equal hundreds of dollars to get a $8 medicine? It just doesn't make any sense. There are things that we get submitted for signature that I just think are relics of the past. Say, our friends in physical therapy, most times we're required to sign off on their treatment plan. And it's really silly because the physical therapists know more about the physical therapy than I do. And ultimately, we want to know what's going on, but a physical therapist doesn't need my approval to continue with the plan. And that should really be something that if I have a problem with how things are going, that then I initiate some communication in addition to them sending us their notes. And there are several things like that with affiliated branches of medicine where it doesn't really need a doctor's supervision. Those things could just happen automatically and save time and effort. If you can think of anything that doctors are currently doing or providers are currently doing that is inefficient and doesn't benefit society as a whole, put that in the comments. I'd love to hear what you think about what we could do to make things more efficient. I want to say thank you to our medical teams across the entire nation, across inpatient and outpatient medicine and all the specialties out there. We couldn't really provide medicine without everybody's involvement, whether it's home health or whether it's hospice. It's a huge system and every part of it is important. And thank you. Go ahead and chew on that, food for thought, and I'll catch you at the next video.